Welcome to Evidence Mastery with Dr. Masood Tosi. I am going to help you understand what obesity is and how it is managed. Please note that this video is for education only and will not replace your doctor's advice. Obesity is a chronic, multifactorial, and relapsing disorder. While it has historically been categorized strictly by body mass index, or BMI, a measurement of weight in kilograms divided by the square of height in meters, the clinical definition is evolving. It is now understood through the presence of excess adiposity and objective clinical evidence of altered organ function. This chart shows the rapid, systemic rise of the condition over the last several decades. Since the late 1970s, global epidemiological data indicates that the prevalence of obesity has nearly tripled. In the United States alone, the rate among adults is currently reported at roughly 40%. The consequences of this shift are severe. In the United States, obesity and its direct complications cause as many as 500,000 premature deaths each year. Beyond the physiological toll, the global economic impact, driven by healthcare costs, job absenteeism, and loss of productivity, is projected by the World Obesity Federation to exceed 3% of the global gross domestic product by 2060. Managing a condition of this scale requires moving past traditional weight thresholds. By shifting the diagnostic focus to clinical criteria that measure specific impairments to organ and functional status, medical professionals can treat the underlying metabolic drivers of the disease. At a basic thermodynamic level, obesity results from a long-standing imbalance between energy intake and expenditure. However, the heritability of BMI across different age groups ranges from 40 to 60%. This genetic predisposition does not follow a simple inheritance pattern. It relies on a complex interplay of multiple genetic loci that dictate metabolic behavior. This logic map illustrates the intricate Sindeli network between the gastrointestinal tract and the brain. Pre-absorptive and post-absorptive signals from the gut provide continuous feedback to the hypothalamus, strictly regulating food intake through competing hormonal pathways. Specific gastrointestinal hormones serve as intake reducers, including GLP-1, or glucagon-like peptide 1, CCK, or cholecystokinin, and PYY, or peptide YY. Competing against these is ghrelin, a hormone secreted primarily by the stomach that functions as the body's primary intake stimulator. Adipose tissue itself secretes leptin, a hormone that informs the brain of existing fat stores. While high leptin levels suppress appetite in individuals with normal weight, the system reacts aggressively to caloric restriction. When weight is lost, leptin levels drop, sending intense, sustained hunger signals to the brain. These homeostatic pathways can be overridden by the limbic system, comprising the amygdala, hippocampus, and prefrontal cortex. This hedonistic pathway mediates cravings, habit, and reward. Through dopamine-driven emotional responses and stress, the desire to eat can completely bypass the body's baseline energy regulations. Several non-caloric factors also drive the condition. Insufficient sleep, getting less than 7 hours a night, alters satiety hormones. The composition of the gut microbiome, medications like glucocorticoids and atypical antipsychotics, and early exposure to endocrine-disrupting obesogens like bisphenol A or BPA all actively promote weight gain. These environmental and biological variables directly alter the body's metabolic set points. By changing how genes are expressed via epigenetics, these factors establish obesity as a deeply rooted physiological condition. This visualization shows a visceral adipocyte acting as an active endocrine organ. Excess visceral fat secretes free fatty acids and the adipoprines directly into the bloodstream, triggering systemic inflammation and insulin resistance across multiple organ systems. In the cardiovascular system, visceral adipocytes release leptin and angiotensin. This activates the renin-angiotensin-aldosterone system, driving obesity-related hypertension. Simultaneously, chronic systemic inflammation from excess adipose tissue accelerates atherosclerosis and promotes a dangerous prothrombotic state. The physical mass of excess tissue causes mechanical destruction. The accumulation of adipose tissue in the tongue and pharynx physically collapses the airway during sleep, resulting in obstructive sleep apnea, or OSA. In the joints, the increased biomechanical load combines with adipokine-driven inflammation to destroy articular cartilage, leading to severe osteoarthritis. The metabolic overload causes significant hepatic damage. It frequently results in metabolic dysfunction-associated steatotic liver disease, or MASLD. Without intervention, this accumulation of fat in the liver creates cellular damage that can progress directly to cirrhosis. The complications extend into the psychosocial environment. Prejudice and discrimination against individuals with obesity directly correlate with elevated psychological stress, clinical depression, poor body image, and disproportionate rates of underemployment. The metabolic, hormonal, and physical activity of excess adipose tissue acts directly upon the body, generating the systemic damage observed in every organ system. Diagnosing obesity begins with BMI thresholds, dividing patients into class 1, 2, and 3 based on severity. However, BMI is a crude screening tool. It fails to distinguish between lean muscle mass and fat mass, and strict adherence to universal thresholds can underdiagnose metabolic risk, particularly in patients of Asian descent. To address these limitations, proposed classifications separate preclinical obesity from clinical obesity. Preclinical obesity is a condition of excess body fat associated with variable health risks, whereas clinical obesity is characterized by verifiable alterations of organ function and a reduced ability to conduct daily activities. Clinicians supplement BMI with direct anthropometric measurements, specifically waist circumference. When available, body composition is analyzed using bioelectrical impedance analysis body water to indirectly calculate body fat, or dual energy X-ray absorptometry, or DEXA, an imaging procedure that precisely details fat distribution. Because of the high probability of comorbid disorders, comprehensive screening is mandatory. This includes blood tests for diabetes and dyslipidemia, and specific diagnostic instruments like stop-bang, a questionnaire risk score used to identify undiagnosed obstructive sleep apnea. Establishing an accurate diagnosis requires recognizing that waist circumference and the presence of metabolic syndrome markers are frequently better predictors of cardiovascular complications and mortality risk than an isolated BMI calculation. The initial clinical target for treating obesity does not require total weight normalization. A weight loss of just 5 to 10% drastically improves insulin sensitivity, lowers blood pressure, and lessens the severity of conditions like obstructive sleep apnea and steatotic liver disease. MAGThink begins with lifestyle modifications, a diet utilizing low glycemic foods, high fiber, and lean protein, paired with 300 to 360 minutes of physical activity per week for weight maintenance. However, overly restrictive diets that cut basal energy expenditure by more than 50% often fail, as they trigger hormonal responses in leptin and ghrelin that strongly favor weight regain. Pharmacotherapy, utilizing anti-obesity medications, or AOMs, is indicated for patients with a BMI of 30 or higher, or a BMI of 27 with specific comorbidities. Legacy treatments include gastrointestinal agents like orlistat, which inhibits pancreatic lipase to decrease fat absorption, and combination therapies like phentermine and topiramate for central appetite suppression. This chart shows the efficacy of modern nutrient-stimulated hormone-based medications. Semaglutide, a GLP-1 receptor agonist, mimics hormones to reduce appetite via the hypothalamus, resulting in a mean body weight loss of 14.9%. Effectively treating obesity means abandoning the expectation of a permanent cure through temporary intervention. It requires the lifelong, stepwise management of a chronic metabolic disorder. Clinical approaches must adjust for special populations, particularly children. Defined as having a BMI greater than the 95th percentile, children face an extended duration of metabolic complications. Data indicates that 55% of children with obesity carry the condition into adolescence, and 70%. It is characterized by the concurrent loss of muscle mass, or sarcopenia, and the redistribution of body fat into the abdominal cavity, largely driven by decreased androgens, diminished growth hormone, and physical inactivity. Because of this visceral fat accumulation, an increased waist circumference is a far more accurate predictor of morbidity and mortality in older adults than BMI. While treatments must account for age-related vulnerabilities, advanced age alone is not a contraindication for bariatric surgery, which maintains similar complication rates in patients over 65. Obesity management must adapt to the biology of the patient's life stage. The focus spans from strict developmental prevention and early surgical evaluation in pediatric populations to rigorous muscle preservation and central adiposity control in the elderly. If left untreated, obesity progressively degrades organ function. After achieving weight loss through lifestyle modification, most patients return to pretreatment weight within 5 years. This biological drive to regain fat stores mandates a continuous, lifelong management strategy. This chronic trajectory is directly observed in pharmacotherapy. When anti-obesity medications are discontinued, the suppression of the hypothalamic hunger pathways lifts, and patients systematically regain the lost weight. Effective prevention depends on several non-caloric factors: managing cortisol through stress reduction, stabilizing satiety hormones with high-quality sleep, and avoiding weight-promoting medications like specific antipsychotics or glucocorticoids. Dietary fiber and aerobic exercise remain foundational, but they are only part of a larger picture. Obesity currently stands as the second leading preventable cause of death in the United States. While the body's homeostatic systems fiercely defend excess fat stores, continuous, multimodal clinical care can interrupt the progression of the disease and mitigate systemic damage. Obesity is a complex, multifactorial disease driven by genetics and governed by intricate neuroendocrine pathways. Accurate diagnosis requires screening for waist circumference and specific comorbidities, and effective treatment relies on a stepwise approach, scaling from structural lifestyle modifications to nutrient-stimulated hormone-based medications and bariatric surgery. I hope you enjoyed this video. Please share your experience or questions in the comments. If you found this video helpful, don't forget to subscribe to my channel. If you want a resource explaining diseases, medical conditions, therapies, and drugs in plain language, I am writing a book, Real World Medicine, Diseases and Drugs. Stay tuned.